Zurich. Before I ask Milo when maybe is the first institution of the CT screening in Switzerland, this is a very important question for me as interventional pulmonologist, because we have to be prepared for a lot of people with positive findings. And I think one of the issues we have to solve before beginning with a CT screening program, we have to be sure what we are doing with a lot of positive findings. And the positive findings that could be like this tumor here, this would be quite simple to reach, but there are other tumors I can show you afterwards. I have no conflicts of interest in relation with this topic, which is very important. Then this is one of our patients, and I'm sure you have seen a lot of patients in your clinics. This is a 79-year-old male. This is not a CT screening program patient. He did have a CT of the chest because of an aortic graft infection. Yeah, the aortic stenosis, which is a very low opening area, severe renal insufficiency and preserved pulmonary function, and he was in impaired performance status. So the next question is, what are we doing with this nodule here? So the diagnosis is quite simple. It's an incidental, not a CT screening founded pulmonary nodule in the right upper lobe. The prevalence in Europe, and I think it's more or less the same in Switzerland, of these incidental pulmonary nodules is about 30%. And what we are going to do, we're going to ask the guidelines, and the European guidelines are saying, in this situation, consider a bronchoscopy. So these are the guidelines from the British Thoracic Society, and you see here, considering augmenting the yield from bronchoscopy using either radial endobronchial ultrasound, fluoroscopy, or electromagnetic navigation, and this is my issue here. But before we are going into the electromagnetic navigation bronchoscopy, I'm going to show you what is the standard situation in most centers in Europe, and this is endobronchial ultrasound. You have this ultrasound probe here, which is going to a 2.8 millimeters working channel of a flexible bronchoscope. This is the picture you are going to have after your probe is into the lesion. The yield is approximately 70% with a very low complication rate. There are some pneumothoraces, but there are no deaths or something like that, and no severe bleeding. You can have tissue and cytology. You have a good bleeding control if there is bleeding, and you can combine this procedure with a mediastinal staging by the EBUS. But there's a con, and this is the broncho sign. I'm going to show you afterwards what the broncho sign is. Just a few films to activate you. This is the driving unit here, which is driving 36 degrees. And here you have the normal bronchoscopic view when you go into the lungs. And this is the probe. And this probe is rotating. And by rotating, you have this ultrasound tip. You're going to reach this picture here. And you can see here, you are in the middle of the lesion. In parallel, you can do the chest X-ray or the fluoroscopy. And then you can see here with both pictures, you have two areas where you can certify that you are within a lesion. Then you can do the biopsy there. As said before, it is cytology and it is histology. So let's go back to our 70-year-old male patient with his right upper lobe nodule. That was an adenocarcinoma, which was confirmed by radial EBUS. The patient went to the tumor board, and we decided, because of his comorbidities, to do radiation therapy. He did not have any signs of metastasis. The challenge of bronchoscopy, now we're going closer to explain what a broncho sign is. If you do conventional bronchoscopy, you only see the central regions of the endobronchial system, but most of the tumors are beyond this visible area of the bronchoscopy, like here. Then you have the situation that you have a lot of orifices, and you have to really an expert in anatomy to see which of these thousands of orifices is the appropriate one. So you have to rely on some kind of navigation bronchoscopy. As said before, one possibility is the radial EBUS, and the other possibility is electromagnetic navigation bronchoscopy. You have a CT scan, and the CT scan goes into a very magic machine, and this very magic machine does make some estimation, like virtual bronchoscopy, to show you the way to the lesion. You see the lesion is here, and this is only a virtual picture. Here is the real picture with the tip of this navigation machine. Then it switches to the CT screen, and now we can see we are 5 centimeters far from the lesion, and then we can find try to find the way to the lesion. It's like a computer game, really. And I think my son, who is 6 years old, is able to do this. But there are some issues. It's very funny, but you never reach 100% safety, or you never reach a diagnostic yield of 100%. This is compared to conventional 14%, you can forget this. If you take fluoroscopy, only 40%, you can forget. But with radial EBUS, you become 73% yield, and with electromagnetic navigation bronchoscopy, you are not better. But this machine has a cost of 300,000 Swiss francs. So why is that? Why is that? This is our own experience here. We have a lone machine here, super dimension. We have done 10 cases in the last 2 months. Okay, we have a learning curve, I agree, but only 2 of these 10 patients had a positive histology, and in one of these I would have reached the lesion by R-EBUS, which is much more cheaper. Now I come to the real problem of navigation bronchoscopy. Every technique at this moment is dependent on this here, on the bronchus leading to the lesion. If you do not have a bronchus who is leading to the lesion, there is no chance to reach the lesion by any endobronchial technique at this moment. If you have a successful EBUS, absent or positive bronchus sign, you can compare 11 to 90%, or if you do electromagnetic navigation bronchoscopy, you are not better than with EBUS. That's the problem. Then you can do other things. You can do virtual bronchoscopy, then you reach 81%. You can do a combination of R-EBUS and navigation bronchoscopy, then become 90%, which is the best result I ever found in the literature. Or you can try to do an ultra-thin bronchoscopy, which very, very small, thin bronchoscopes, where you can reach the pleura, but also then you are dependent on endobronchial ways, and you become a yield of 74%, so it's not better. So I made some estimations. If we would begin with a CT program in Switzerland, then Switzerland has 7 million people. It's nothing against China, I know. We have ages 46 to 75. We have 3.2 million people eligible for a CT screening program, according to the NSLT NSLT paper, was 780 patients. That will be annual number of CT scans of 400 CT scan, and annual number of these pulmonary nodules, or these positive findings, as Professor Puhan said before, is 100,000 positive findings in 1 year in Switzerland, in addition to what we have already now. So we have really prepared with any technique to find out what this patient has. That it can be surgery, I agree. That can be bronchoscopy, or that can be CT-guided core biopsy. So we have to be prepared for these additional findings. Here, this is a very, very new technique. And there's only a first-in-man study, which was published 2015 by Felix Hurt in Heidelberg. This technique is not dependent on the bronchosign. You go with your bronchoscope and with your tip to a point where you make a hole here. This is a drill machine, and then you can cross country through the interstitium of the lung into this lesion. And then you can reach a yield of, 83%. But again, it is not 100%, although you are not dependent on the bronchosign. We have tried to make this in a pig. That's myself here in Heidelberg, trying to be better than 83%. I never reached 100%, even in a pig. This is very nice. It's funny to play with that. But I'm really not sure if the money is worth to buy this really expensive machine. But there are chances to do more than only diagnosis, and I know I raised the criticism of our radio-oncologists. Maybe we can do a dye localization or a fiducial marker playing, or we can do maybe a therapy like a direct destruction of this lesion. But these are only dreams. There are no papers on that at the moment. So I come back to the guidelines, the BTS guidelines. We have a great D recommendation of augmenting the yield of bronchoscopy by using endobronchial ultrasound, fluoroscopy, or electromagnetic navigation. But I have to add, only if a technology is independent on the bronchosign, then we can reach about 80 or maybe 90% diagnostic yield. That's the end of my presentation. I'm happy to have some questions from your side. Okay, thank you, Daniel, for your presentation. Are there questions to the audience? I'm the chair. I cannot ask myself. Right. Yeah, it's a good question. The question is the comparison between CT-guided bronchoscopy techniques or maybe video-assisted thoracic surgery biopsy. I think if the lesion is very peripheral to the surface of the lung, then indeed CT-guided biopsy or a WETS biopsy is appropriate. If the lesion is more centrally located, then I think a bronchoscopy technique would be more appropriate, because the side effects of the CT-guided biopsy technique is a 25% pneumothorax rate. So you have to consider about that. Yield is about 95%, that's right. Yeah. But you cannot stage in the same setting. This is an advantage of the bronchoscopy techniques, that you can combine diagnosis and staging in the same procedure, and the patient can sleep.
Doing these things, but for these small nodules, staging is usually not the problem. It's a diagnosis.
Yeah, it's for the bigger one.
For the bigger ones, you don't need navigation, right?
I think there's not one solution for every. We have to discuss. Yeah. Okay. Then I have the